Thank you, Mr. George. Our next speaker is Paige Morrow. She is a licensed and clinical social worker. She is also the director of the Renfrew Center of Bethesda, Maryland. Thank you very much for inviting me to come speak with you all today. Eating disorder statistics are daunting. 1/3 of all patients will get better. 1/3 will cycle in and out of treatment, and 1/3 will die. Let's take a look at the role insurance plays in the latter two groups of people suffering with eating disorders. Managed behavioral health was created to lower overall employer health coverage costs and pass savings along to employees. At the core of this mission was the idea that if clinicians oversaw other clinicians who abuses such as years of daily psychoanalytic therapy or patients who were locked away in state mental institutions for most of their lives would become a thing of the past. Those of us who entered managed care early on in its inception were passionate about ensuring that our patients received good clinical care. We had the power to do something about it, and we did. After all, money talks, and once you threaten not to pay for ineffective treatment, people are surprisingly willing to change what they are doing. With strict oversight from these managed care companies, providers soon began to utilize the tenets of a short-term treatment model. Over time, patients were enjoying faster symptom relief at lower costs both to them and their employers. Patients returned to work and to their lives faster. Our clients' productivity levels increased and staff turnover and the use of disability benefits decreased. We did our jobs and we did them well. After several years, we sensed a shift in our mission. The goal was no longer to ensure that our members received the most aggressive and progressive treatment. We noticed that our performance was being reviewed against how much care we authorized. We got the message very quickly that those who authorized treatment too freely were either disciplined or replaced. We knew to cover ourselves by sending the more complex cases to the psychiatrist to review so that their name would be on the authorization, not ours. As the years went on, more managed care companies entered the market, and as they merged to create larger, more powerful companies, competition for contracts became fierce. You see, how rigorously a patient's case is reviewed is solely dependent on two things. One, how much profit is built into that contract. Number two, what expectations does the employer have about how they expect their employees to be treated, and whether this level of treatment is reflected in the price of the contract. This all translates into whether your treatment is covered or not. I served as manager of the Health Plans Division of APS Healthcare and was later promoted to Vice President of Clinical Operations for Magellan Health Services. I left because I was constantly pressured to push the ethical boundaries of my profession. I am a clinician first and foremost, and I became so because I want to help patients, not find ways to deny them care. It was my job to control the number of authorizations my units issued each month. I'd like to describe some of these methods that we used for you, particularly as they pertain to eating disorders. Now that I sit on the other side as a provider of treatment, I can see the devastating effects these methods have had on the entire system. In all actuality, for all the rigmarole that insurance companies go through to contain costs, it does just the opposite for them and for us, especially when it comes to the treatment of eating disorders. Tactic number one. Managed care is short-sighted, and it worries more about its monthly authorization numbers than on long-term success rates for consumers. When you bake a cake, you usually bake the cake at 350 degrees for about an hour. Managed care believes you should turn the heat up to 500 degrees and bake it in half the time. This may result in a cake that looks done on the outside, but it will not be fully cooked on the inside. And if left out on the counter, it will collapse into itself because the center isn't solid and can't sustain itself when it comes out of the mold. I offer this analogy to illustrate how managed care pushes providers to expedite treatment of eating disorders to save money. Patients must be refed first to gain access to their emotions, which takes time. Once they are feeling again, they need time to gain insight into how their emotions are playing out on their relationship with their food. If this does not occur, the old coping mechanisms are reactivated once everyday stressors are reintroduced to their lives, like a return to work or school. Patients have no option but to fall back on their old patterns of behavior. Success in this particular area cannot be rushed. With every failed episode of treatment, most patients will internalize their treatment failure. They think, I must be failing at my eating disorder because the insurance company doesn't think I'm sick enough, and they up the ante. They feel like failures themselves when they are unsuccessful in each attempt to control their disease, and they feel helpless. Renfrew, Maryland has two 14-year-old girls in our program right now who were recently denied continued coverage in our partial program after just 2 weeks of treatment. We had no choice but to step them down to our intensive outpatient program, knowing full well that they were being set up to fail. Sure enough, both patients lost weight after just 1 week and now are in need of readmission back to our partial program. Managed care does not listen to treatment providers, which is wrong and difficult to understand. It interrupts a critical treatment process that works if it's allowed to work. With every failed course of treatment, the possibility of recovery for these patients becomes harder and harder to even imagine. Tactic number 2. Managed care uses inappropriate medical necessity criteria. Only in the last 5 years have managed care companies begun using eating disorder criteria. Some don't use them at all, and none of the ones managed care uses match the criteria set forth by the American Psychiatric Association. Using regular medical necessity criteria for eating disorder cases is like comparing apples to oranges. Only authorizing treatment when a patient becomes suicidal, homicidal, psychotic, or in need of detoxification couldn't be further from what the issues are in eating disorder treatment. It is absurd and dangerous for a governing body not to speak the same language as the credentialed providers it has hired to deal with these very serious, in fact, life-threatening issues. Tactic number 3. Managed care stipulates a certain number of treatment days care managers are allowed to authorize. The current trend is 2 to 3 days, and they often have unrealistic expectations as to what can be accomplished in this very short time frame. Sometimes care managers won't authorize further care, and the cases are sent up the managed care food chain for a higher level of review. This can take 1 to 2 unauthorized days, which leaves patients at risk of having to pay for those days out of pocket, which can be quite costly. Several problems result from this tactic. Number 1, generally, most patients can't take the strain of going through this process every few days, and they voluntarily terminate treatment. Number 2, it is distracting for any patient, and they are unable to engage in treatment for fear of opening up and having to leave. As a practice, this really drives costs up for both sides. Managed care is paying for multiple clinicians and psychiatrists to review one case through multiple levels of appeals. On the provider side, we too have to pay multiple different clinicians and psychiatrists to go through this process. To do this every 2 to 3 days results in a shocking loss of revenue for both sides. Is it any wonder that our premiums and the cost of care escalate because of all this craziness? Tactic number 4, managed care creates the catch-22. If during a review we indicate the slightest improvement, for example, let's say the patient follows her meal plan the previous evening, or has a really productive family session, the insurance company will often stop authorizing treatment for the patient, saying progress was made and she can now be treated safely on a lower level of care. On the other hand, if the patient isn't making a lot of progress, they may deny coverage, saying the treatment plan is not effective. They like to say that they are consumer focused, but they need to understand that treatment of eating disorders is not a linear process. They need to learn about it and understand it, rather than hold on to counterproductive review strategies. Tactic number 5, managed care relies on numbers to determine care. Managed care focuses on percentage of ideal body weight to review care. The problem is this: it effectively eliminates patients who struggle with bulimia or binge eating disorder. These patients need treatment just as much as those suffering from anorexia, but because they look okay on the outside, they are not reviewed by the same consistent criteria. This is discrimination. Weight is by no means the correct or only indicator of a need for treatment. The Renfrew Center of Philadelphia has been treating a patient we'll call Susie every year for the last 3 years in its residential facility. Susie was 14 when she first came to Renfrew. She is diagnosed with anorexia nervosa and has been admitted each time between 68 to 70% of her ideal body weight. Every year, the insurance company ekes out 2 to 3 days at a time and ultimately denies care once she's reached 75% of her ideal body weight. Each time they say she has consistently gained weight and can safely be managed in a partial hospitalization program. This poor patient is still so far underweight by all reasonable standards except insurance ones that she should remain in the residential setting. There is no partial program within 1 hour of where she lives. So each time, Susie feels like she's failed again and must try to succeed in her recovery by only seeing a therapist 2 times per week. Susie hasn't shown up for treatment this year, and we don't know what has happened to her. If a patient can remain in a secure environment like a residential program, or be governed for breakfast or lunch in a partial hospitalization program, they will gain weight. If there is no evidence that the patient has gained some insight into the many factors affecting their eating disorder, they will decompensate upon discharge. Cutting the course of patient treatment short each time sets patients up to fail. If families have to or can pay out of pocket in order to complete the recommended length of treatment, the financial ramifications are often devastating. This cycle, it also creates a level of guilt in each patient that serves to forestall the possibility of ultimate recovery. When I was a care manager, we were encouraged to treat patients fully, with every appropriate method at our disposal, because this saved money in the long run, as patients got better and did not need multiple episodes of treatment. This thinking is important, but has been lost. Tactic number 6. Managed care fails to disclose contractual saturation rates to consumers. When managed care contracts are signed by employers, they typically stipulate that an insurance company is required to maintain saturation rates for all of its members. What this means is this: within a 50-mile radius of where you live, the insurance company agrees to saturate your area with enough treatment providers to treat your illness appropriately and effectively. If a patient with an eating disorder needs a partial level of care, but there is no program available in their area, the insurance company has a legal obligation to pay for an out-of-network program, or they must authorize a higher level of care. In the case of the patient we spoke of earlier, Susie, a key issue is this: why didn't her case manager disclose what coverage their policy provides, so she could be admitted to the right program and could receive effective care for her disease? If a suitable program wasn't available in her area, why didn't her case manager authorize her continued participation in the residential program in which she was making progress? Insurance companies almost always lay low and wait for a layperson to ask the right questions. They are not forthcoming with information that would benefit patients, and they cover themselves by relying on the fact that it is the patient's job to know what the insurance's policies and procedures provide, and it is not their job to educate them. Everyone here has probably felt frustrated, angry, or been unfairly treated by their health insurance company. Your premiums are used to advertise how much your insurance company cares about you, and to industry lobbyists that they hire to protect immoral practices that harm patients, not towards paying for your care. That treatment doesn't serve anybody and is not cost effective. Doesn't it make more sense to make the right treatment available for patients the first time so they can recover, rather than try to wear patients and their families down with paperwork, excuses, bad advice, and financial debt? We are not stupid. We all know that the goal of an insurance company is to take money in and not pay it out. The time and energy wasted on unproductive conversations with insurance providers and their utter failure to even try to understand the nature of eating disorder treatment undermines our patients' recovery and makes life very difficult for involved families. And sometimes it even kills our patients. It is time for us to make a change. Congress needs to pass the federal response to Eliminating Eating Disorders Act today so that people can get the care they need. So the two 14-year-old kids currently in my program can get well, rather than struggle down the same hopeless path as Susie. Stop the revolving door of care. It will save money.